Professor Dr. Osama الغنام, the chairman of and the president of the Egyptian Society of Stem Cell, and he talked about and the former dean of the Faculty of Medicine, and is the head of Department of Neurosurgery, former also. And now he will talk about stem cell therapy for spinal cord injury Egyptian experience. And he began this experience since 2004 in first animal and clinical studies in spinal cord injury and in neurological disease, in many diseases, in multiple sclerosis, in amyotrophic lateral sclerosis, and in stroke. And he began the stem cell therapy in Egypt. Thank you, Dr. Osama.
Thank you much indeed. In fact, it's a combined lecture. I will just speak about the clinical part, and Professor Wael will carry on afterwards. When we started that long time ago, we really were very, it was just a dream, an idea. And we needed courage, time, effort, and finance as well. And we have to convince and discuss with the patient and volunteer, especially when something very new, you know, anything new, you find lots of objections from societies, even from your colleagues and doctors. So that's why we started very softly, gently, and kindly as well, with careful experimental research, and then later on clinical research. So we started, when we started to the clinical work, we took the who are desperate, helpless, hopeless, and they have nothing to be offered for them. No medical or surgical treatment could be given to them. And so nowadays we can say that the dream become true. And the lots of diseases we used there, we started, of course, before that, the spinal cord, but one of them is the cerebral palsy. And when we say about cerebral palsy, we have a lot of them in Egypt, I'm afraid, because of the lack of care of maternity and childhood. And then we investigate the case and see how big is the cerebral cortex, the size of the cerebral cortex. We don't use who have marked atrophy of the brain. We take a good thickness with less functional normality. But in case who are marked atrophy, really, we try to take them away. And also, we don't take cases who are too late to have lots of skeletal muscle deformities. You cannot bring that back again. In other cases like post-traumatic malacia, which again we have a lot of them, but not the whole brain malacia, just special parts which are affecting the function of the brain. Also that, we take that. Whatever the cause of malacia, from trauma or infection or even infarction. Multiple sclerosis, also one of the cases. Alzheimer's disease, giving a promising trials as well. Some of the hereditary ataxias, Parkinson's disease, autism in children, one of the cases. Muscle dystrophies, Duchenne, one of the distressing factors, especially when it is familial, and you see 3 or 4 kids in the same family. It's a disaster and calamity of the family. So also these cases been tried very well. Spinal cord injuries, I must say, this is the part which we started with, because the patient is devastated, the family is devastated, and the doctors also are devastated. They can have fixation of the spine, of the bony part, but nothing for the nervous element, nothing for the cord itself is being really offered except this stem cell treatment. And whatever the location, we know that the cervical cord affection is the best, the lumbar and sacral region is the best, but the dorsal core injury is the worst of them, which really they don't have good prognosis, whatever you do. But stem cells give a glimpse of hope toward that. And then we trying a motor also disease, motor neuron disease, like LS or lateral sclerosis, hereditary spinal paraplegias. And then we try to make refining over the year, because we started that in clinical practice since year 2005. And we found that we take the younger the age is better, the duration and the, we don't take too long post-traumatic. We take them the earlier the better, 1 month, 2 months, and sometimes we do them during the fixation surgery. When we fixate, we open the dura and we inject the stem cell directly. This will probably give a good chance because you localize the part and you give the stem cell inside the core, the damaged core. We try to segregate or exclude the cases who have spinal deformity, whatever gibbous, and also have contractures, and cases who have lots of many segments. We choose 1 or 2 segments, but if you have more than 1 segment, more than 2 or 3 segments of the cord being damaged or become malacia, that's not going to improve at all. And we used to do once, but now the injection, the variable, guided by the lab colleague, who sometimes give it intrathecal and intravenous as well. And of course, after trying all the sources, we found the richest part, which organ, which gave mesenchymal cells, is the spinal cord. And we used to give intravenous, intrathecal, intraventricular, intramuscular, intraspinal cord itself during surgery. But the commonest we use is the intrathecal injections. And clinically, the effect, they show some improvement, but they never come back to normal. We don't take the hopes up to the sky. We just tell them, we may give you some help to make you just walk, go to the toilet with little or no support, but they're not going to come back ever again. And we give them the percentage of not more than 20 or 30%. I think I will leave my friend Dr. Professor Wael to carry on, and thank you very much for your attention.